Laurens is joining us from University of Western Australia this evening to talk about better penicillins, better hearts, rethinking long-acting penicillins for rheumatic heart disease. And Professor Manning is an infectious disease physician and clinical researcher at the Fiona Stanley Hospital, University of Western Australia, and is an honorary fellow at Telethon Kids Institute. He has a diverse research portfolio ranging from diabetic foot infections, periprosthetic joint infections, and paediatric malaria in Papua New Guinea. He leads the Strep A therapeutics team at Telethon Kids Institute, tasked with repurposing long-acting penicillin preparations for rheumatic heart disease and syphilis. And so I'm hoping that you're there with me. Laurens, you're there?
Well, thank you, Susie and Jason and the team in Brisbane for the invitation. I'm really disappointed I can't be there in person. I was sort of going back through my previous presentations to the Microsampling Symposium back in 2017 and 18, and reflecting on how much fun it was to be there. So hopefully in the future I'll get a chance to catch up again. So I would take a little bit of a step away from the really interesting stuff on sensors that was just presented and sort of maybe take it back to a clinical world where we've actually taken a microsampling assay and used that to underpin a whole lot of research into optimizing a particular therapy. And in this case, I'm going to share our group's work on long-acting penicillin, which is used for rheumatic heart disease. And so you can see there, these are some crystals which were first manufactured in the 50s. And what they worked out is that if you combined penicillin moieties with some benzathine, that these things would crystallize into an insoluble powder. And when you resuspended that, you could actually inject it into the muscle or, as you'll see, under the skin. And very slowly, that compound of the crystals would dissolve and slowly release penicillin into the bloodstream. And that's been the main treatment for rheumatic heart disease for nearly 70 years. And the traditional approach is to give it intramuscularly and give it every month. And it hasn't changed for all of that time. So we're dealing with an old drug. As I said, there are about 40 million people around the world with rheumatic heart disease, and it causes 300,000 deaths per year. Most people will get most certainly if you're over 30 kilograms, you'll get 900 milligrams or 1.2 mega units intramuscularly every 4 weeks. And you're supposed to have that for between 5 and 10 years at least. Now, as it happens, the same drug is also used to treat syphilis, and particularly late syphilis and in antenatal syphilis, patients will get 2.4 million units intramuscular once a week for 3 weeks. And as you can kind of imagine, the downsides of such regular injections in the muscle present some huge programmatic challenges to health sector providers, and adherence is very poor. And then in Australia, there's another group of patients who might eventually benefit from better penicillins, and that's those patients who are needing secondary prophylaxis for cellulitis. And there's some sort of ideas about what the burden of disease is in Australia for that. So there's a diverse range of conditions that this antibiotic's used for. Globally, there are 2 ways that it's formulated. And in Australia, we have a pre-filled, ready-to-use syringe, and that's it's called Bicillin, and that's available here in Europe and the US. It has a whole lot of disadvantages. Firstly, it's not stable at room temperature, and the other main downside is that it costs a lot. So it's about $30 per dose. But for most parts of the world, they get a powdered formulation, which is cheap, but it's not very easy to reconstitute. You have to reconstitute it in mortar. And because it's a suspension of these kind of crystals, it often clumps. and it causes needle clogging. So again, patients hate it, nurses hate delivering it. And the other downside to this is that there's actually no WHO qualified or pre-qualified active product or API. And that's created a real bottleneck for large funders to procure this particular medication for on behalf of country health departments. There are only there are basically only four companies around the world which manufacture this particular API, and they supply the rest of the world, who will repackage it and distribute it within their own settings. And three of those companies provide 95% of the world's supply, and they're all based in China. And as I said, there's real uncertainty about the quality of manufacturing, and there's no the quality of GMP and WHO pre-qual hasn't actually ever been met. And the reason for that is that the quantities required are small, and there's limited profitability to be made with this because, as I said before, the powdered formulation is so cheap. So you've got a terrible market. You've got a drug that people don't like, that people don't adhere to. So how do we make this better? So I guess when we talk to the experts, there's a sort of product profile that we consider to be the ideal profile that will take us away from a painful monthly injection. And that would be one that would last for somewhere between 3 and 6 months, that wouldn't hurt, that would ideally be administered subcutaneously, that wouldn't have any issues with cold chain independence, would be independent of cold chain, and would be cheap. So that's the aspiration, certainly for amongst the experts in the field. When we look at what children and adolescents and it's often children and adolescents who are receiving these medications, and young adults, what are the kind of ideal injection characteristics? And this is a systematic review of injectables in adolescents that was done by a medical student in our team. And what do they want? Well, they want things that minimize the impact on their quality of life with reduced frequency. They want a product that has ideal design features that are reliable and also tolerable. They want control over their health outcomes, and they want to minimize conflict and any challenges with the home healthcare interface. So I guess sort of putting those last two slides together, there's a sort of a whole lot of aspirations about what both we think as a group of scientists and healthcare providers, what's going to be the ideal solution, and what the patients who are actually receiving these medications want as well. So this was the problem that we were presented with about 5 years ago. How do we make BPG better? And so we started with an assay. Well, how do we actually measure penicillin, and how can we do that in settings where patients are actually receiving these medications, and how do we understand the pharmacology of this particular medication better? And Susie and I have had many conversations about what the best microsampling strategy is, and obviously probably as we move along, the dry blood spots are probably a bit simple, but we found particularly for penicillin, measuring penicillin in the blood, that it actually has been a really effective way to assay penicillin out in the community. So we started off with a bridging study in patients receiving penicillin in hospital settings, and you can see that we, across a really wide range of concentrations, that the reliability was pretty good. Although what we found is that, and I've sort of shown this dirty laundry previously at this particular symposium, is that when we took blood from PICC lines to assay, it seemed like the penicillin, for people who are receiving continuous infusions of penicillin, it seemed like the penicillin was absorbing on the inside of the catheter, and we had quite spurious results at particularly high concentrations. But overall, the assay performed very well, both in terms of its reproducibility and CVs and so on. What we did notice, though, was that there was quite a lot of thermal degradation, and certainly when we got to 35 degrees or higher, we saw early and substantial degradation. So that presented us with some problems, particularly because we wanted to run these studies in tropical climates and in urban areas where we were doing outpatient visits. And in WA, in Western Australia, sometimes the temperatures are over 40 degrees, and inside a car, for example, it might be close to 50 degrees. So we've had to redo our stability, the top stability studies at 45 degrees even, and we've developed a solution where we do the drying in a pretty low-tech box there with desiccant, a box of desiccant, and then put it into a car fridge. And with that strategy, we've managed to demonstrate that it's stable for use out there in the community. So when we tried to understand penicillin, we thought, well, okay, we're injecting this insoluble compound into a compartment like subcutaneous tissue or muscle, and at the beginning there's a small amount of water which gets absorbed, and then we start seeing crystal dissolution, and that can happen over days to weeks. And what that kind of told us was that renal clearance for a drug like penicillin, which has a very, very rapid clearance, that actually renal clearance have very little impact on the final concentrations. And actually what we see in the plasma is very much dependent on the absorption characteristics. So that was our first insight, which obviously seems obvious now. The other factor around this particular medication is that the concentrations that you attain with standard dose intravenous penicillin in a hospital setting for endocarditis or enterococcal infections are very high, and they sort of range in the concentrations. We use nanograms per mil, and they might be up to 50,000 nanograms per mil. Whereas for benzathine penicillin, where really the concentrations are very 3 orders of magnitude lower than that, and the sort of traditional target for bicillin for rheumatic heart disease is 20 nanograms per mil, or 0.02 milligrams per litre. So we very much needed to have an assay that was very sensitive at low concentrations, because the concentrations attained with this particular medication were also very low. So one of the first studies we did was we've done 2 PK studies to try and understand the pharmacology, both in Indigenous Australians, adolescents with rheumatic heart disease. The first was in what we called a rural setting, which was in the Northern Territory, and the second was an urban study of urban Aboriginal kids with rheumatic heart disease. And the first thing we found is that, and this was a sort of an unexpected finding, is that actually, the curve here, the black curve here, is what happens if you give an intramuscular injection to a normal sized adult, and it's confirmed to be in the muscle. And basically what happens is that you get a pretty rapid peak concentration, and then we see this very slow decline. And just for context, each one of those little dashes along the x-axis is 1 week. So in effect, what we really see is concentrations above the target of 20 nanograms per mil really for only 1 week every month. And you can see that it declines quite quickly, declines below that concentration early on. And so we've got 3 weeks at least, as far as we know, which are below the target concentrations. And this data is consistent with data that's been shown from all studies of benzathine penicillin. And this is a systematic review of PK of benzathine over time. So this basically an aggregate of all the global data on this. And you can see, again, most concentrated. As we move through the time, most people get below 20 nanograms per mil at about a week or so. So we think, well, actually, we're sort of presented with this interesting dilemma as why is it so effective when our target concentration seems to be not met. And so one hypothesis is that of course the target is much lower than it actually is, and we're in the process. This is Thal Pla, who's a PhD student and infectious diseases physician, who's we're just about ready to start in the next couple of weeks as a human challenge trial to see whether or not to work out exactly what concentrations required to prevent experimental pharyngitis with strep A with penicillin. The minimum concentration of penicillin to prevent streptococcus. In the second of the PK studies that we did, we had this really interesting observation. Again, this was all using the dry blood spots, and what we saw is that it was like if you had normal body mass index compared with a body mass index greater than 25, they were like different populations. And the absorption half-life, certainly the most important absorption half-life, was doubled in that particular group. And that was for us, that was a really striking observation, because we hypothesized that this might be due to inadvertent subcutaneous injection, even though the target was the muscle, just because of subcutaneous tissue thickness, that you wouldn't actually be able to inject it into the muscle. And then what we were seeing is the effect of subcutaneous injection versus intramuscular injection. And just to remind you, it's intramuscular injection which has been the standard for the last 80 years or 70 years. So we took that one step further and we said, well, what would happen if we did a crossover trial of intramuscular versus subcutaneous injections? And this was a trial, again, it was done in a clinical trial facility, but it was underpinned by the dry blood spots. Although what we did do is, for internal validity, did at least one venous sample, paired venous and DBS sample at a time point for each participant. And what we found is, you can see that the black line is the intramuscular injection, and the red line is what we'd seen was with deliberate subcutaneous injection. And that basically showed, when we did the model, that the PK model demonstrated that the absorption half-life was doubled, confirmed to be doubled in subcutaneous injection versus intramuscular injection. And on the right here is numerical pain score, which demonstrates that the pain was exactly the same, or depending, didn't really matter whether you gave it intramuscular or subcutaneously in terms of tolerability. So we thought, okay, subcutaneous administration, that's something which we're interested in. And then we sort of asked the question, well, at the moment we're giving one of those vials of 2.3 mils of penicillin. What would happen if we cranked up the dose? Could we deliver up to, say, 9 times that dose as a subcutaneous infusion? And in doing so, perhaps that would buy us more time between injections, because that's the target, is to buy time between injections. And so we said, well, okay, that's an interesting idea. So we fiddled around for a little while trying to work out how we might deliver this. And we settled on this spring fuser device. And in a 30 ml syringe, we put 9 of those penicillin vials into one syringe. And then we attached it to the syringe driver, and we did a phase 1 trial of subcutaneous infusions, which lasted about between 15 and 30 minutes with a flow controller. And so basically, I won't sort of bore you too much with this slide here, but the middle panel shows the pain scores at different time points. And the comparator in red is what you'd see with a single intramuscular injection of 2.3 mils or 1.2 mega units. And the green is what you'd see with a subcutaneous infusion of a much higher dose. And you can see over time, these are the skin. What you see on the skin at the beginning is a sort of a small lump under the skin, which didn't you know, hurts a little bit, but the same as a intramuscular injection. Sometimes some very minor bruising, which settles down over time. And this is what you see on ultrasound with that. On the left-hand side, you can see the residual bicillin or benzothine crystals within the subcutaneous tissues, and that gradually dissolves over time, and by day 112, it's gone. And as expected, the PK profiles that we obtain with this particular mode of administration were very much consistent with what we expected. And in this particular graph, this is a time concentration graph with a log scale, again, for 8 and 12 weeks. And so in the red, you could see what would happen with a intramuscular injection given every month. And with the blue line is what you see with the subcutaneous infusion of penicillin, which we're calling SCIP. And the time that you attain above the target of 20 nanograms per mil with the standard dosing is about 40%, and with a very high dosing, it's much higher. So we think that actually, obviously there's some challenges with delivery of this particular medication. You know, how do you implement such a strategy? But at least this is one mechanism that one might be able to think about increasing the duration between injections for patients with RHD. And alongside that, this is the model of what would happen if people started thinking about self-administering subcutaneous bicillin as a weekly dose, but using a smaller volume. And with 1 ml given subcutaneously every week, which is essentially the same frequency as some of the new diabetes medications, you can see that the target of 20 nanograms per ml is met 100% of the time. So that's another approach which we're considering. And for syphilis, the SCIP, the mechanism for SCIP using the dosing that would be appropriate, the same total dose for late syphilis. You can see what would happen if you gave, on the red is what would happen if you gave 2.4 mega units weekly for 3 doses, and what would happen when you give the whole dose in one clinic visit at the beginning as an infusion. So the time above the target for syphilis is 18 nanograms per mil, and you can see the time above that concentration is longer for an infusion than if you give the standard dosing. So we're just about to start a phase 2 trial of SCIP syphilis in Fremantle at the moment. So I guess I've been talking for a little while. I hope I haven't overdone it, but we've got a number of steps along the way. This is sort of a program. Again, none of it would have been possible without the base work and the using a microsampling approach using dry blood spots. So we're going to work on the human challenge model to work out what the actual target is. We've got another study of SCIP2 of SCIP in New Zealand adolescents and children with rheumatic heart disease. As I said, we've got SCIP syphilis starting in the next few weeks. And then we're working on other ways to try and improve cold chain and syringeability issues so that we could maybe implement mini SCIP down the track. There's the team. It's a sort of a mushrooming team of people, and they're a fantastic group to work with, and our funders and collaborators. So I think I'll leave it there. Thanks so much for your attention.
Thank you, Laurens. It was a great talk and clear example we can make better use of by rethinking how we administer our drugs. Thank you.